Let's think about acute encephalopathy. These are patients who are quite sick. You'll see them overnight in the ER and on inpatient scans. And we're going to look at it in three different image patterns. We're going to look at focal patterns, leptomeningeal spread, and then more diffuse patterns. And we're going to focus mostly on diseases that are not stroke. There will be a few stroke cases, but mostly to expand our differential beyond stroke and to think about the other categories of disease. Let's start with the temporal lobe focally. So here's a case. What do you think? We have hyperintensity and some modeled enhancement throughout the anterior temporal lobe medially involving the amygdala, the hippocampus. We have some restricted diffusion. What is your diagnosis? This is herpes encephalitis. This is one that you want to really consider because there is treatment. We could start acyclovir. So always think about this with temporal lobe involvement, and so that treatment, the right treatment, can be started right away. One to remember for the ER. What's the findings here? Here we have bilateral medial temporal lobe involvement. We have involvement of bilateral amygdala, bilateral hippocampi, and then the chest CT demonstrates a mass. This is a patient with a lung cancer with limbic encephalitis. And review the temporal lobe anatomy. Be able to label the gyri, the hippocampi. What's the finding here? We see restricted diffusion bilateral medially in the temporal lobes. This is what artery causes the infarction. MRA also demonstrates tip of the basilar thrombosis. This is a stroke case. This is one that you'll know about. This is a venous infarction. Again, straight sinus, vein of Galen, internal cerebral veins thrombosed. Remember to think about venous infarction, especially the unusual situation where you have deep venous thrombosis. What do we have here? How do you describe the findings? We have diffuse pontine abnormality with signal abnormality, and this is osmotic demyelination syndrome. This is a classic look for osmotic demyelination syndrome also. This is a classic pattern. How would you describe it? What is the diagnosis? Here we have periaqueduct gray involvement, and also you often will see involvement of the mammillary bodies. You can even have encephalitis of the midbrain. It's a diagnosis that we're going to find by other means. So we have MRI, and then a lot of these patients are going to require lumbar puncture to get more specific diagnosis. So this is an encephalitis, a viral encephalitis involving the midbrain. Bilateral symmetric, it's going to be a hard one to notice. Let's go on to the next imaging pattern, leptomeningeal disease. Here's one. Take a moment to describe the findings. We have hydrocephalus, we have edema surrounding the ventricles, and if you look at the middle image on FLAIR, we see some signal laying dependently within the occipital horns, and then we have enhancement of the ventricles. What is this? This is ventriculitis. Describe the imaging findings here. Here we have leptomeningeal enhancement. Here you see enhancement throughout the cerebellar fissures. This was a leptomeningeal carcinomatosis. What's the finding here? Here we have a basilar predominant leptomeningeal enhancement. Our differential is a bit more specific. We're going to think about sarcoidosis. We're going to think about tuberculosis. This is a case of tuberculosis, meningitis. You can see hydrocephalus too. This is a case of meningitis that we can actually see leptomeningeal enhancement. Often we won't see any findings with meningitis, but here we do. There are more rare infectious causes of leptomeningeal enhancement. This is an amoebic meningitis. What are the findings here? We have dilated perivascular spaces. Often you'll see enhancement in this diagnosis. and this is a case of cryptococcal meningitis, which likes to go to the perivascular spaces. This is a case of CMV ventriculitis, and we can see restricted diffusion and some ventriculomegaly and restricted diffusion surrounding the ventricles. Two rare diseases. Here's one, and here's another rare disease, one for pediatrics. Now let's focus on diffuse patterns. This is the first one that you're going to think about. This is, describe the findings. This is restricted diffusion throughout the cortex and deep nuclei. Um, we can miss bilateral symmetric imaging patterns, and so we're going to window that really tight. We're going to see that there's true restricted diffusion basically everywhere, that the gyral sulci are too bright. And the first thing that you'll come to mind, and you see it quite often, is a person who had cardiac arrest and a diffuse hypoxic injury. And it can be from hypoxia. This is one from hypoglycemia. Again, the structures that are most metabolically active, deep nuclei, cortex, are the ones most involved. The imaging appearance at first looks quite similar on this diagnosis, except this would be a patient with progressive decline over days and weeks, and presents with dementia and confusion, may even be an outpatient, and this is restricted diffusion in cortex and basal ganglia and patchy regions, and this is CJD. The other big one that you see quite commonly and you do quite well with is distribution that's posterior. This is posterior reversible encephalopathy. So now let's think about viral diseases that are diffuse. And these aren't specific, but we're going to think about these viral encephalitis in patients who are quite sick and who have either basal ganglia, thalamic, and cortical involvement in that same kind of diffuse pattern. And so this is West Nile encephalitis. From time to time, we have outbreaks of West Nile encephalitis in Dallas. This is a Japanese encephalitis, same sort of pattern. These patients are quite sick. This is a tick-borne encephalitis, and in that spectrum, we're going to see the same sort of findings in this. This is a patient with status epilepticus, and that is with status epilepticus, we can have restricted diffusion in cortex, and it can be from the encephalitis, or it can be just from status epilepticus, and sometimes both exist. Let's think about one. Here's another one that first looks just the same and has restricted diffusion and looks catastrophic, but this is someone with liver failure and very high levels of ammonia. And so these regions are potentially reversible with treatment. So this is a similar pattern, but very different prognosis. Let's think about toxic diseases. And there's a whole range of these, right? So this happens to be methanol intoxication. This is a case of carbon monoxide poisoning, which is the same thing as hypoxia. This is a case of cocaine toxicity. This is a case of methotrexate toxicity. This is from heroin inhalation, otherwise known as chasing the dragon. There are a lot of other potential causes for infection, but let's focus on COVID. With COVID, we see a lot of strokes, we see parenchymal hemorrhages, and we see large vessel clots. And in the third phase, we see these very unusual patterns. And this is one to know of where there's restricted diffusion that really doesn't fit in an embolic pattern or a classic watershed, but is something in between. And so you can have a look at this pattern, and this can be from COVID. The last category is to think about autoimmune diseases. And this could be lupus, it could be Hashimoto's. This is a version of autoimmune disease involving the cerebellum. And so in that last category of autoimmune diseases. So this is our three big imaging patterns that we've covered. And some of them are classic and mini type examples. And some of them we figure out through further workup using history, CSF analysis, and other lab values.